Hello, Insta family. It is Dr. T here, Tuesday night rapid fire Q&A. And I got to tell you, you've got me in my trachea. You have me in, I think, my oldest jumper. In fact, it's pretty close to having some holes in the elbows. And my tracheodax. That's what you've got tonight. Sorry, guys. How are you? I hope you're all really well. Ooh, another big week. I always find this end of the year is just cray-cray. I don't know about you guys, but I look at my diary and I'm like, oh my God, Christmas is around the corner. Hello from Scotland. Lovely to have you on. I was just going to try and say your handle, but I'm not even going to bother. Welcome. So I don't know about you guys, but I find this end of the year is just nuts. And we're about to hit September tomorrow. No, the day after. And then we'll just roll down into December. And then it'll be Christmas all over again. Hello. Lovely to have you on. Hey, guys, this is awesome. So we are all about questions. So here is the C word. What did I say? I'm just trying to think back on what I just said that was wrong. Rapid fire Q&A Christmas. Yes, thank you for clarifying. I thought I'd said something really wrong. Yes, no, you're right. I probably shouldn't say it because it just starts my heart racing as well. So, guys, fast, rapid fire Q&A. Remember, today is questions, guidelines. Oh, I'm so not with it. I am doing this challenge, this body transformation challenge, which I do once a year. And it's because I'm a little bit competitive. And I always find this last 4 weeks, so I'm just entering this last 4 weeks of this challenge quite full on. So I start training at 4:30 every morning. And I have to get to bed. So I'm sorry, a little bit brain dead. But everyone knows our guidelines, right, around rapid fire Q&A. So ask a question, keep it short, try really hard to ensure that the question is kind of generic, not too much about your personal history. And then you can, and then the answers that we have will make as generic as possible. Okay, so anyone have any good questions? Here we go. Brooke. Amber Joy. Metformin, diabetes and PCOS correlation. Oh, great question. My favorite topic. And I've talked about this quite a lot today. Okay, so polycystic ovarian syndrome is exactly that. It's a syndrome. In fact, it's an endocrine disorder that just so happens to have gynecological implications. That's why you end up coming and seeing someone like me. And often it requires you to have some assistance with fertility. Why? Because you don't know when you're ovulating. And so it makes it really difficult to time intercourse. But about 40% of women who have PCOS also have metabolic syndrome. What is metabolic syndrome? It's a combination of high cholesterol, high blood pressure, sometimes overweight and obesity, and increased risk of cardiovascular disease and insulin resistance. And all of those risk factors kind of make up metabolic syndrome. So 40% have a risk of developing metabolic syndrome. Now, what's the role of metformin? Well, insulin resistance is managed by metformin. So if you have features of the metabolic syndrome, then there's a role for metformin. Additionally, if you have optimized your lifestyle such that there's no obvious feature of insulin resistance, what we do know though is that metformin is a really good adjuvant, so assistant to helping with ovulation induction, particularly in those who have already optimized their lifestyle and their body weight is below a BMI of 30. And that's what a lot of the evidence shows. How it works, it's an insulin sensitizer. So it helps to really drop that insulin drive, which will help drop the androgen drive, which hopefully then will promote ovulation. So we don't use it as an ovulation induction agent, but it helps. And the other benefit to metformin is if you have to have IVF, which is not the right treatment for PCOS, by the way, but if you have to have IVF, then it helps to reduce your chances of developing ovarian hyperstimulation syndrome. So there you go. It's a great drug, fantastic drug. Use it liberally, and that's its role and association with PCOS. Hopefully that was helpful. Now, someone else asked a question. Bub and Mum, what does embryo glue do and is it effective? Oh, such a great question. I've got to be careful what I say here. Embryo glue is a product. It is, I'm not exactly sure what its full makeup and composition is, but it's designed to help increase the stickability of embryos when you do a transfer. So you put it into the transfer media. Does it work? It's a great marketing campaign. The evidence seems to suggest that embryo glue does not necessarily increase pregnancy rates. And because of that, I don't necessarily advocate it for everybody. Hopefully that's the right answer. Mum and Bub and Mum, thanks for asking the question. All right, who else has a question? Somebody else has got to have a question. Here we go. Will estrogen pessaries during FET cycle cause a flare-up in endometriosis? Great question, Teen Time 232. I guess biologically plausible that they will. We certainly know that women, even though in a cycle you're only stimulating for a really short period of time, you do that repeatedly, then any estrogen is going to drive endometriotic deposits. We know that an IVF cycle can flare endo. Therefore, it's biologically plausible that an estrogen, which is a bioidentical, is also going to flare endometriosis. So one of the things that I think is really important is to not linger too long in treatment if you have a history of endometriosis, because almost certainly the treatment they would give you is going to make it worse until such time as you fall pregnant. And then when you fall pregnant, all of that progesterone that your body is producing is going to just smash down that endo and dissolve it away. And then the aim is to try and keep it away until such time as you have your next pregnancy. But great question. Okay. How many tries do you usually advise for IUI before moving to IVF? Well, look, the success rates with IUI are not that high. So on average, obviously it depends on clinic to clinic, but on average, you've got about a 15% chance each month. It's not fabulous. The way I counsel patients, it's kind of like double your background chance of success. Where I would use IUI probably more liberally is in our FIFO population. When blokes are away and we need to do ovulation induction and the guy's not around, I'll often need to revert to IUI because he's just not there. So I think it's really reasonable if you've got such low chances of success with IUI, that you move on fairly quickly. And so we know that success rates probably really plateau after about 3 IUI cycles. So I probably wouldn't labour on it much beyond that. The other thing that you've got to think about too is the treatment burden. So think about, all those blood tests and monitoring, triggers, waiting for pregnancy tests. Like, that's burdensome for a woman to be doing that. And you do 3 cycles of that, and to do that for a 15% success rate, I don't know if you'd labour on much more than that. But I certainly would be having the conversation after about 3 cycles. Mrs. Carvello, do you know the stats on how many women are overstimulated during egg collection? 10%. Okay, depends on how you define overstimulated. Like, ideally, we're getting somewhere between 10 and 15 eggs collected. So if you're saying over 15 is overstimulated, or are you referring to ovarian hyperstimulation syndrome, which is a cluster of symptoms? So we know severe OHSS can sit at around about 1%. But I think most women you talk to going through IVF will tell you that they're experiencing some symptoms. some bloating, some tightness around the abdomen, sometimes a bit of pain, a bit of constipation, a bit of sort of dark urine, so a little bit dehydrated. So a lot of women will complain of those kind of symptoms, and obviously it's a bit of a spectrum through to severe symptoms. Hopefully that kind of answers your question. But I don't know of a woman who sort of kind of sails through and go, oh, that was fantastic, let's do it again. I think every woman finds controlled ovarian hyperstimulation quite challenging. Jane 357911, PCOS. How long postpartum to expect period to come back? How long to wait to see someone to try for a baby, like me, to try for a baby? Okay, so polycystic ovarian syndrome, the biggest issue is what derangement of hormones is leading to you not ovulating. So it really depends on how bad your PCOS was to start with. Some women just simply do a little bit of exercise, watch what sort of food they eat, maybe drop a few kilos, and the cycles kind of revert to normal. Whereas for other women doing that, they still have really resistance. So let's just talk about the average woman who doesn't necessarily have PCOS. If you're breastfeeding can give you lactational amenorrhea, so it's kind of contraceptive because you don't necessarily ovulate when you're breastfeeding. Once you start to reduce the feeds, then often cycles will come back pretty quickly. It's very rare for someone to be postpartum and then stop breastfeeding and then not have a return of cycle unless they have some underlying pathology like PCOS. And the return of cycle, look, I would reckon that you should absolutely have your cycle back once you're starting to drop your feeds, particularly your night feeds, within a couple of months. And if you're not breastfeeding at all and not having cycles within a month of stopping breastfeeding, I would definitely be going and having your baseline bloods assessed to make sure that there's nothing impacting on that. Montana Arden, I've read that you can get the worst period of your life following IVF. Do you know what? I think I would say just by clinical experience, a lot of women complain of that. And there's probably a few reasons for that. Number one, we've completely hyperstimulated your lining. So you think about it, at the peak of your IVF cycle, your estradiol is often in the tens of thousands. And in a normal ovulatory cycle, it peaks out at about 1,000. So we have supraphysiological levels of estrogen stimulating the lining of your womb. So it's going to get pretty thick, right? And then you've got to shed that. So yes, I think relatively speaking, periods can be worse. The other thing too is that we've stuck needles in your pelvis. We've stuck needles in your ovaries. Your follicles in your ovaries, often even into the next cycle, can be quite big, sometimes still filled with blood. And, you know, we've kind of traumatized you in going and doing an egg collection. So everything's a little bit sore and tender. And so it doesn't surprise me really that the period can be quite heavy and quite painful. Sorry, I'm not selling this very well, am I? Honestly, there are some good outcomes, really. Okay. All right. Oh, these are fabulous questions. Thank you so much for asking them. I hope they're helpful answers. Sarah Molyneux, is it worth having a laparoscopy to check for endo if severe period pain is the only symptoms and severe endo? So if you are not being alleviated, Sarah, with simple management, perhaps by going on the combined pill, by simple analgesia, if you've tried a lot of conservative methods, even with a normal pelvic ultrasound, even with a normal pelvic examination, if you have debilitating symptoms, I think it's very reasonable to talk to an experienced gynecologist about diagnosis, and particularly in the context of fertility, because I've seen a lot of patients with absolutely no symptoms. Yeah. I just went on hold. Sorry, guys. What are the main symptoms of endo? They can range from nothing to fatigue. All right, guys, I'm going to lose connection very soon, but the symptoms of endo are wide and varied. Okay, I am getting constant messages to say that my connection is really poor. Oh my God, there are so many questions. I'm going to answer one more. And then guys, I want you to come back next Tuesday night and ask away. So last question for me tonight. Is there anything you can do for adeno when starting IVF? Worried it will cause implantation issues. We don't know the answer to that, teen. We don't know the answer to whether adenomyosis is a problem with implantation failure. Often because adenomyosis comes in the context of fibroids and sometimes even in the context of endometriosis. There are different stages and severities of adenomyosis. There is a thought that perhaps those who are asymptomatic with adeno don't have implantation issues, whereas those who are symptomatic might have implantation issues. But the jury's really not out on that. The issue with adenomyosis is that it's under the influence of hormones, much like endo. So unless you're going to suppress it with hormonal suppression, there is very little that you can do. And unfortunately, all of the hormonal suppressants are also contraceptive. So we're kind of between a rock and a hard place. Adenomyosis that's often diffuse within the walls, very little that you can do about it because the treatment of adeno really is hysterectomy. And that's not going to serve you if you're trying to conceive. So it is a very difficult pathology to manage. We're still getting our head around it as we're better at diagnosing it now with better resolution ultrasounds. But I don't think unless you have recurrent implantation issues, I don't think it's worth worrying about at this point in time and until you actually need to worry about it because there's not a lot that we can do that's not going to cause harm and injury to the uterus itself. Okay, guys, I have been well over my normal 10 minutes. Two Souls Co, Sugar Kitten, Return to Zenda. Guys, please, yes, damn internet connection, sorry. Can you come back to me with these questions next Tuesday? I would really like to address them. It's been an absolute pleasure. I love jumping on here with you guys. I had a story to tell you, but I didn't even need to because the questions just started rolling in. Have a beautiful week. You know where I am. You know where to find me. If you find these sessions really valuable, make sure that you share them with as many people as possible. And I'll see you next Tuesday night. Bye, guys.